Welcome back. Today we're focusing our deep dive on BRCA1 and BRCA2. Now, for many people, these names can bring up a lot of anxiety, maybe fear. But for you, listening now, we want to turn that into power. We've gathered a range of sources detailing how inheriting changes in these specific genes really reshapes the whole calculus of cancer risk, not just for an individual, but potentially for an entire family.
That's absolutely the mission here. We're taking what can be really complex genetics, the science of inherited risk,
Yeah.
and we're aiming to distill it down into clear, actionable knowledge, information you can use for proactive health management. If you know your BRCA status, or maybe you're wondering if you should know, this is about giving you a solid footing to make those choices.
Okay, so let's start with the basics. What are BRCA1 and BRCA2? Everyone has them, right? 2 copies of each.
Exactly. They're essential genes. Think of them as producing proteins that act like a crucial repair crew for our DNA. Day in, day out, our DNA gets damaged. Little breaks happen. These BRCA proteins are supposed to step in and fix that damage, keep things stable.
Right. So the problem starts when there's an issue with one of those copies.
Precisely. The risk kicks in when you inherit a harmful change, what scientists call a pathogenic variant or a mutation, in just one of those 2 copies from a parent.
Okay.
So you might still have one normal working copy initially, like a backup.
Okay, a backup system. Makes sense.
But if that second normal copy gets damaged or lost later in life, and that can just happen randomly as cells divide, or as we age, it's called a somatic alteration, then that whole DNA repair system fails in that cell line.
Got it. So losing the backup is the trigger.
That's the point where things can go wrong.
Yeah.
That failure allows errors to build up in the DNA, potentially leading to uncontrolled cell growth, which is essentially how cancers like ovarian and breast cancer can start to develop.
And we really need to stress the scale of this risk increase. It's not just a slight nudge. Inheriting a harmful BRCA change, it catapults someone from a general population risk level to a very, very personal high-risk category.
The numbers are quite stark, but it's important to grasp them to understand, the gravity of the situation. Let's take female breast cancer.
Okay.
In the general population, the lifetime risk is around 13%. That's roughly 1 in 8 women.
Standard statistic, yeah.
Yeah. For women who inherit a harmful BRCA change, particularly BRCA1, that risk, it jumps dramatically. We're talking over 60% lifetime risk. Some studies push it even higher.
Wow. Over 60%. That's more than a 5-fold increase.
Easily.
Yeah.
And it doesn't stop there. Say a woman has breast cancer and thankfully survives. The risk of getting cancer in the other breast, contralateral breast cancer, is also way up.
Right. That's a major concern, too.
Definitely. Sources show that within 20 years of the first diagnosis, maybe 30% to 40% of BRCA1 survivors and around 25% for BRCA2 face a second primary cancer in the other breast.
Compared to what in the general population?
Compared to only about 8%. So again, a massive difference. It's a persistent elevated threat.
And then there's ovarian cancer. Often includes fallopian tube and primary peritoneal cancer too, right?
Correct. They're often grouped together because they behave similarly and likely originate in the fallopian tubes.
And the risk shift there is just astronomical. General population risk is tiny, about 1.1% lifetime.
Almost negligible for most people, but for a woman with a harmful BRCA1 change, that risk can soar to between 39% and in some studies up to 58%.
Almost a coin flip in the worst case.
Pretty much. And even for BRCA2 carriers, while generally lower than BRCA1, the risk is still significantly elevated, maybe 13% to 29%. Way above that 1.1% baseline.
And crucially, this isn't just about women's health.
Not at all. That's a key message. Inherited BRCA changes significantly raise risk for men, too. Prostate cancer is a big one, especially with BRCA2.
How big?
Well, the general population lifetime risk for prostate cancer is around 10.6%. For men carrying a harmful BRCA2 variant, estimates suggest the risk by age 80 could be anywhere from 19% up to a staggering 61%.
Hold on, 19% to 61%. That's a massive range. Why such variability?
Yeah, it's a really wide range. It often comes down to, which specific populations were studied, the exact ages they looked at, how long they followed people, and maybe even which specific BRCA2 mutations were most common in that group. Different studies use different methods, but the consistent message across all of them.
The risk is much higher.
Much, much higher. Carrying BRCA2 puts men into a high-risk category that definitely warrants earlier and more focused screening discussions.
And you also mentioned male breast cancer.
Yes, it's rare overall, maybe 0.1% lifetime risk for men in general. But for BRCA2 carriers, that risk increases significantly, perhaps up to 7% or so by age 70. Still rare, but a real increase.
And pancreatic cancer.
That affects both men and women with these mutations. The risk goes up maybe up to 5% for BRCA1 carriers, potentially 5% to 10% for BRCA2 carriers, compared to about 1.7% in the general population.
So multiple cancer types involved.
Right. And there are even some rarer associations mentioned in the sources, like melanoma, maybe stomach cancer. The point is, a harmful BRCA variant casts a wide net in terms of potential cancer risks across the family for both men and women.
Okay, so faced with these kinds of numbers, the obvious question becomes, how do I know if this applies to me or my family? We know the general prevalence is low, right? Like 1 in 400 people overall.
Right, about 0.2% to 0.3% in the general population carry a harmful BRCA change. But, and this is a big but, that average figure can be really misleading.
Oh, so?
Because in certain populations, the prevalence is much, much higher. The classic example is people of Ashkenazi Jewish descent. About 1 in 40 or 2% carry one of 3 specific founder mutations.
Founder mutations, meaning they originated a long time ago in that group.
Exactly. A mutation that started in a smaller group of ancestors and became more common in their descendants. And it's not just Ashkenazi Jewish populations. Sources mention founder mutations in Norwegian, Icelandic, Dutch, even some West African groups, among others.
So ancestry and family history are huge clues. What are the key things that should make someone listening think, okay, I need to talk to my doctor about genetic testing?
There are several clear indicators. The absolute strongest is if you already know a family member carries a harmful BRCA1 or BRCA2 mutation. If so, you should definitely be tested.
That makes sense. What else?
Ashkenazi Jewish heritage on its own is often considered enough to warrant a discussion about testing, given the higher prevalence.
Okay.
Beyond that, it's about the pattern of cancer in your family or your personal history. Things like breast cancer diagnosed at a young age, say 50 or younger, or personal or family history of ovarian cancer at any age, or male breast cancer, pancreatic cancer, or certain types of prostate cancer like metastatic or very high-risk cases.
So specific cancer types and ages are critical flags.
Yes. If you see those patterns, it's time for a conversation about germline genetic testing.
And how is the testing actually done? Is it complicated?
The test itself is simple, usually just a blood draw or a saliva sample. That's because if you inherited the mutation, it's in essentially every cell in your body. It's a germline mutation.
Okay. And you mentioned genetic counseling. Why is that so important?
Oh, it's absolutely essential before you even do the test. Genetic counselors help you understand what the test can and can't tell you, the potential results, and the implications, not just medical, but emotional, familial, even financial sometimes. It's about informed consent.
Making sure you know what you're signing up for.
Exactly. And they also help ensure the right test is ordered for your situation. Which brings us to a really important warning about some direct-to-consumer tests, those kits you can buy online.
Ah, the home testing kits. What's the issue there?
The concern is that some popular DTC tests might only look for those 3 common Ashkenazi Jewish founder mutations. They don't test for the hundreds or even thousands of other possible harmful BRCA variants found in the wider population.
So you could get a negative result.
And think you're in the clear.
Yeah. When actually you might have a different BRCA mutation they didn't even test for.
Precisely. It can create a dangerous, false sense of security. So comprehensive testing through a healthcare provider, guided by genetic counseling, is really the gold standard.
Okay, so you've gone through counseling, had the test, the results come back. Let's break down the main possibilities for the listener. First up, a positive result.
Right. Positive means a harmful pathogenic variant was found in BRCA1 or BRCA2. This confirms you have that markedly increased risk we've been discussing.
But crucially,
it does not mean you will get cancer. It's not a guarantee. It's a statement about probability and risk. But it absolutely means you need a proactive management plan.
Okay. Then there's a negative result. This one can be a bit tricky, can't it?
It can be. The meaning really depends on your family context. If there's a known harmful mutation in your family, say, your mother tested positive for a specific BRCA1 variant, and you test negative for that specific variant.
That's good news.
That's genuinely reassuring news. It means you didn't inherit that particular risk factor from that side of the family. Your risk related to that variant basically goes back down to the general population level. You also can't pass it on to your children.
Okay. But what if there isn't a known mutation in the family? You're the first one tested, perhaps, based on family history, and your result is negative.
That's what we call an uninformative negative. It means you don't have one of the common harmful variants they tested for. but it doesn't rule out that there might be a different, maybe rarer genetic risk factor running in the family that we just haven't identified yet. Or maybe the cancers in the family aren't due to BRCA at all.
So it doesn't give you a complete all clear in that case.
Not entirely. Your management would still likely be guided by your family history in that scenario.
Right. And the third possibility, the VUS.
Ah, yes, the variant of uncertain significance, or VUS. This means the lab found a change in the BRCA gene. But right now, scientists don't have enough evidence to say definitively whether that specific change actually increases cancer risk or if it's just a harmless variation.
That seems incredibly frustrating for someone to hear.
It really can be. It creates uncertainty. But the positive side is that most VUS results, as more data comes in over time, are eventually reclassified. And the vast majority get reclassified as benign, meaning harmless.
So what do you do in the meantime with the VUS?
You manage risk based on other factors, primarily your personal and family history of cancer, not based on the VUS itself. You essentially treat it as an uninformative result until more is known.
Okay, so let's say the result is positive, or maybe there's a strong family history even with an uninformative negative. What does proactive management actually involve, starting with screening?
For women, enhanced breast cancer screening is key. This usually means starting screening much younger than the general population.
And using different methods.
Yes. Typically involving breast MRI, sometimes with contrast, often in addition to or alternating with annual mammograms. MRI is generally better at detecting cancers in younger women and those with dense breasts, which can be more common in BRCA carriers.
Makes sense. But what about ovarian cancer screening you mentioned earlier?
Yeah, this is the really tough part. Despite decades of research, our sources are clear. There are currently no proven effective screening methods for ovarian cancer that reduce mortality.
That's stark, given the huge risk increase.
It is incredibly frustrating. Methods that were tried, like transvaginal ultrasound and the CA-125 blood test, unfortunately haven't been shown to catch the cancer early enough consistently to save lives when used for screening in high-risk populations. They might find cancers, but often not early enough to change the long-term outcome.
So the focus shifts away from screening for ovarian cancer.
It shifts heavily towards risk-reducing surgery, which we'll get to, and very importantly, symptom awareness.
Okay. What about screening for men with BRCA mutations?
Good question. Recommendations often include discussions about prostate cancer screening, starting earlier, potentially more frequently,
Right.
especially for BRCA2 carriers, due to that higher risk we talked about.
Right.
And also discussions about clinical breast exams and potentially even annual mammograms for men, again, particularly with BRCA2, because of that increased male breast cancer risk.
Mammograms for men, that might surprise some listeners.
It might, but it reflects the underlying biology and the increased risk.
Okay, beyond screening, there are more permanent options, risk-reducing surgeries.
Yes, these are major decisions, obviously, because they're irreversible, but they are highly effective. For breast cancer, there's bilateral risk-reducing mastectomy removing both breasts. This can lower the risk of developing breast cancer by 90% or even more.
A dramatic reduction.
Huge. And for ovarian cancer risk, the main surgical option is bilateral risk-reducing salpingo-oophorectomy, or RRSO. That's the removal of both ovaries and fallopian tubes.
And that helps with ovarian cancer risk how much?
It drastically reduces the risk of ovarian cancer, often by 80–90% or more. And importantly, because many ovarian cancers are now thought to start in the fallopian tubes, removing the tubes is critical. It also provides a secondary benefit of reducing breast cancer risk, particularly if done before menopause.
But there's a significant downside, especially for younger women, right?
Absolutely. Removing the ovaries induces immediate surgical menopause.
Right.
So there needs to be careful counseling about managing menopause symptoms, bone health, cardiovascular health, all the consequences of losing estrogen production early.
A major trade-off to consider. Are there non-surgical options, like medications, chemoprevention?
There are some. Medications like tamoxifen and raloxifene are FDA approved to reduce breast cancer risk in women at generally elevated risk. Tamoxifen specifically has been shown to reduce the risk of contralateral breast cancer in BRCA carriers who have already had cancer in one breast.
Okay.
The role of these drugs for primary prevention in BRCA carriers is maybe a bit less clear-cut compared to surgery, but it's an option discussed.
Any surprises in the sources regarding medication?
Well, one perhaps unexpected finding relates to oral contraceptives, birth control pills.
Really? How so?
Data suggest that women with BRCA1, or BRCA2 mutations who have ever used oral contraceptives seem to have about a 50% lower risk of developing ovarian cancer compared to carriers who never used them.
Wow, 50% lower risk. That's significant.
It is. Of course, oral contraceptives have their own potential risks, like maybe a slight increase in breast cancer risk or cardiovascular concerns for some women. So it's a complex discussion with pros and cons. But the potential protective effect against ovarian cancer in this high-risk group is noteworthy.
Let's circle back specifically to ovarian cancer. It's often called the silent killer. We need to really clarify for listeners why it's so hard to detect, especially as women get older, moving into postmenopause.
Yeah, the silent killer label comes from the fact that symptoms are often vague and easily dismissed until the cancer is quite advanced, and it predominantly affects older women.
What age range are we talking?
Over 80% of ovarian cancer cases are diagnosed in women over the age of 50. The average age at diagnosis is around 63.
So risk definitely increases with age.
It does. Part of that is likely just the natural accumulation of DNA damage in cells over a lifetime. For someone with an inherited BRCA mutation, that age-related damage is layered on top of their existing genetic vulnerability, accelerating the risk.
And the symptoms, they're treacherous because they overlap so much with other common issues, right? Like menopause itself or digestive problems.
Exactly. That's the core challenge for early detection based on symptoms. We're talking about things like persistent bloating or a swollen abdomen, pelvic pain, or maybe lower back pain that doesn't go away, feeling full very quickly when eating, or just a general loss of appetite, and changes in urinary habits needing to go more often, or feeling a certain urgency.
Things that many women, especially postmenopause, might experience occasionally anyway.
Precisely. The key difference and what women need to watch for is the persistence and frequency of these symptoms. Are they new? Are they happening almost daily? Has they lasted for, say, 3 weeks or more?
So it's not just having the symptom once, it's the pattern.
Yes. If you notice that kind of persistent pattern, that's the signal to see your doctor promptly and specifically mention the possibility of ovarian cancer. Don't just assume it's IBS or aging.
Given there's no effective screening, this reliance on symptom awareness seems critical, but also precarious.
It is. It means diagnosis often happens at later stages when the cancer is harder to treat successfully. Sources mention that in places like the UK, there's currently no national screening program for ovarian cancer for this very reason, the lack of a proven test. It really comes down to symptom awareness and then diagnostic tests like the CA-125 blood test and pelvic ultrasound once symptoms arise.
Okay, so diagnosis can be late, but let's end this part on a more positive note. If cancer is diagnosed, how does knowing someone has a BRCA mutation actually help with treatment?
This is where knowing the BRCA status becomes a huge advantage therapeutically.
How so?
Because the very reason BRCA mutations cause cancer, that faulty DNA repair mechanism, also creates a vulnerability in the cancer cells.
An Achilles heel, basically.
Exactly. These cancer cells are terrible at repairing certain types of DNA damage. So treatments designed to cause that specific type of damage are particularly effective against them.
Like targeted therapies.
Precisely. A class of drugs called PRP inhibitors, you might hear names like olaparib or rucaparib, are designed to exploit this weakness. They essentially block a backup repair pathway, and since the main BRCA pathway is already broken in the cancer cells, the cells can't fix the DNA damage caused by the drug, and they die.
So the treatment targets the cancer-specific weakness.
Yes. PRP inhibitors can be highly effective in patients with BRCA-mutated cancers, whether inherited or acquired later by the tumor. Also, traditional chemotherapy drugs that damage DNA, like platinum-based agents such as cisplatin, tend to work better too. Knowing the BRCA status opens the door to these highly effective, personalized treatment strategies. #outro.
So we've really covered a lot of ground today, from understanding the basic function of these BRCA genes to the staggering increase in risk that mutations cause, through to who should consider testing, what the results mean, the really tough choices around screening and prevention, and finally, that critical need for symptom awareness, especially for ovarian cancer postmenopause.
And I think the key takeaway for you listening is really about agency. It's about knowledge being power, understanding your personal risk, your family history. That's the absolute first step towards personalized medicine.
Taking control.
Exactly. Whether that leads you to pursue enhanced screening or consider risk-reducing surgery or simply commit to being highly vigilant about persistent symptoms. These are all proactive choices, choices that allow you to manage an inherited risk rather than letting it manage you.
Okay, so here's a final thought for you to ponder as we wrap up. We've
Yeah.
talked about incredible progress identifying genes like BRCA, developing targeted therapies like PRP inhibitors, yet ovarian cancer lifetime risk for the general population is still around 1 in 91, and we still lack an effective population-wide screening test for what remains a leading cause of cancer death in women. So the question is, what does this gap tell us about where research desperately needs to focus next?